Esophagus, esophageal perforation, etiology, traumatic, pathological, spontaneous. Traumatic, instrumental using esophagoscopy, the commonest cause, 65% of cases during removal of foreign body or structure dilatation. The commonest site is at the level of the cricopharyngeus muscle. Foreign bodies, swelling of corrosives, penetrating or blunt injuries to the neck or the chest. Pathological, as in carcinoma. Spontaneous, the condition is likely to affect victims of head trauma and drunken. In both situations, there is vomiting, uncoordinated esophageal motility. The lower esophagus fails to relax in front of the forcibly ejected vomitus. Pressure markedly rises in the lower part of the esophagus, and its wall is stretched. The wall gives away either partially, where the mucosa only is split, producing severe bleeding, Matary-Vest syndrome, or completely through the whole wall thickness, Borov's syndrome. The tear is longitudinal, one in the lower part of the esophagus, and it's usually situated in its left posterior aspect. Foreign bodies, swallowed foreign bodies, may be arrested in the esophagus at points of physiological narrowing. If the foreign body is really opaque, it will be visualized by plain X-ray. Otherwise, a dilute barium swallow will reveal it. Foreign bodies can be removed by the rigid or the fibro-optic esophagoscopy. Clinical picture: severe pain at the site of rupture. The patient is acutely ill with fever, tachycardia, and hypotension. Mediastinal emphysema appears as crepitus at the base of the neck, later subcutaneous emphysema over the chest wall and neck. If the rupture penetrates the pleural cavity, pneumothorax or pleural effusion leads to respiratory distress. Investigations: plain X-ray, pleural effusion, hydropneumothorax, air in neck or mediastinum, gastrographin swallow. The best for diagnosis, it reveals the site and extent of rupture. Treatment: cervical perforations, thoracic perforation, and abdominal perforation. For abdominal perforation, need early surgical interference. Cervical perforations, nail by mouth, IV hyperalimentation or fluids, nutrition, drainage of the extravasated fluid, intensive antibiotics. If the case is early, surgical closure may be successful. Thoracic perforation: if the diagnosis is early, suture of the perforation or close the perforation by a flap from the gastric wall and put a chest drainage. If the diagnosis is delayed, esophagectomy and gastric pull-up operation with chest drainage may save the patient. Any attempt to close the perforation will fail. Abdominal perforation, as I said, needs early surgical interference. Corrosive esophageal injury. Etiology: swallowing of corrosive acids, alkalis, or household bleaches. The common example is potash. Pathology: the extent of damage depends on the concentration and the chemical agent, the duration of tissue contact. Corrosive acids lead to coagulative necrosis, prevents deep penetration, less injurious than alkalis. The corrosive injury: chemical burn of the oropharynx, larynx, esophagus, or the stomach. The burn may involve superficial layers of the esophagus, whole thickness, leading to perforation of the esophagus. The injured wall of the esophagus will be replaced by scar tissue and leads to stricture. Management: ensure that the patient has patent airway, the first to be done. Inquire about the timing of ingestion, the identity of the agent, the amount ingested. Chest wall and abdominal erect X-rays are performed to detect any esophageal perforation, pneumomediastinum, gastric perforation, air under diaphragm. Avoid emetics or neutralization of the caustic material, as it may cause exothermic injury. Pain control: course of antibiotics and corticosteroids for 4 to 5 days. Nail by mouth until fiber optic endoscopy is performed within the first 24 to 48 hours. The endoscope should be stopped at the site of severe circumferential injury to avoid perforation. In mild lesions, patients are fed orally. Do barium esophagogram after 3 weeks, even if there are no problems. In severe lesions, no oral intake. Nasogastric tube is introduced under endoscopic guidance for nutrition and as a stent. Barium swallow after 2 to 3 weeks to plan for definitive treatment. Later definitive treatment: esophageal dilatation using bougies or balloon dilators, performed every 1 to 2 weeks and usually 3 to 4 sessions. Gastrostomy allows retrograde dilatation, easier and safer. Surgery. Indications: tight structure with failure of dilatation. Dilatation is hazardous. Surgery is done first. Do gastrostomy to attain acceptable nutritional state before definitive surgery. Then colon bypass is done. Achalasia of the esophagus. Definition: functional disorder of the esophagus which is characterized by weak peristaltic wave in the body of the esophagus and failure of relaxation of the cardiac sphincter during swallowing, functional obstruction with progressive dilatation of the esophagus. The exact etiology is not known, but there are series: degeneration of the vagal fibers and the ganglia in the Auerbach's plexus of the esophagus, autoimmune disorder as there is infiltration of the esophagus by T lymphocytes. In barium male, if the esophagus is interrupted above the diaphragm, it's mostly carcinoma of the lower end of the esophagus, but if the cardia below diaphragm is narrowed, it's mostly achalasia. Clinical picture: type of the patient, more oftenly in second to fourth decades, equal in both males and females. Symptoms: dysphagia, postural regurgitation, and pulmonary symptoms. Dysphagia, painless, slowly progressive, long-standing, two fluids more than solids, at first intermittent, but as the disease progresses, it becomes constant. Postural regurgitation, foul-smelling. Pulmonary symptoms as aspiration, wheezing, and chronic cough. Signs: general condition of the patient is usually reasonable, contrary to patients with carcinoma of the esophagus. Investigations: barium swallow, the main diagnostic tool. In early cases, some holdup of barium at the lower end of the esophagus. In advanced cases, dilatation of the esophagus and maybe tortuous, called sigmoid esophagus. Smooth round termination of the lower end of the esophagus, leading to sign called hen's or parrot peak. Absence of air in the fundus of stomach due to continuous stagnation of fluids in the esophagus. Plain chest X-ray, fluid level in the thorax, widening of the mediastinum, absent air bubble, and aspiration pneumonitis. Esophagoscopy, the main value to exclude carcinoma, which may complicate 5% of cases after 20 years. It reveals dilated esophagus full of retained food and fluids. The cardia doesn't relax and may be eccentric in position, leading to golf hole appearance. Manometric studies: weak peristaltic waves after deglutition, failure of relaxation of the cardia in response to swallowing. Treatment: surgery, the most reliable method, medical treatment, and forceful dilatation of the cardia. Surgery: cardiomyotomy, Heller's operation, bithoracic or abdominal approach. Expose the lower part of the esophagus, cut the muscle fibers completely until the mucosa bulges through the incision, not extending to cardia depending on the manometry. Can be performed whether by open or laparoscopic methods. Advise the addition of an anti-reflux procedure. Medical treatment of very limited clinical value: nitrates or calcium channel blockers, forceful dilatation of the cardia, pneumatic pressure balloons using Regiflex tube, hydrostatic balloon, special balloon introduced at the region of the cardia, then inflate the balloon, rupture of the circular muscular fibers, relieving the distal esophageal obstruction. The esophagus is dilated to diameter 3 cm and the balloon is maintained for 1 to 5 minutes. Dilatation may be complicated by hemorrhage or perforation. 60% of the patients remain well after 1 year, while only 30% remain symptomless after 5 years. Recently, injection of botulinum toxin in the wall of the esophagus as a spastic segment is tried. Gastroesophageal reflux disease, or GORD or GERD. Definition: reflux of gastric contents into the lower part of the esophagus. Incidence: the commonest upper digestive disorder, 45% of the population having reflux symptoms. Peptic esophagitis is the commonest endoscopic diagnosis, occurring in 25% of cases having upper GI endoscopy. Physiology of the gastroesophageal reflux: alone, it's physiological phenomenon which occurs after meals, up to 50 reflux episodes every 24 hours. Most are short-lived. Exposure of the lower esophageal mucosa to pH less than 4 shouldn't exceed 4% of the 24 hours period. If exceeds this level, esophageal mucosa sensitization occurs. Mechanisms resisting reflux: competence of the cardio-esophageal junction, esophageal clearance by the refluxate by 2 mechanisms. Competence of the cardio-esophageal junction due to combined action of lower esophageal sphincter and factors maintaining high pressure zone of 15 to 25 cm water. Lower esophageal sphincter, which is physiological rather than anatomical. Factors maintaining high pressure zone of 15 to 25 centimeter mercury. The intra-abdominal esophagus, lower 3 cm, closed by intra-abdominal pressure. The action of diaphragmatic crura, especially the right crus, closure of the lower esophagus during deep inspiration or during sudden rise of the intra-abdominal pressure, as in sneezing and coughing, acute angle of Hess, abrupt insertion of esophagus into the stomach, the mucosal rosette, valve-like action at the lower esophagus, esophageal clearance of the refluxate by two mechanisms, volume clearance and chemical clearance. Volume clearance due to normal peristalsis during swallowing, chemical clearance, neutralization by swallowed saliva, alkaline due to high bicarbonate content. These two mechanisms short the contact time between the refluxate and the esophageal mucosa. Diffuse esophageal spasm or corkscrew esophagus. Pathophysiology: in this condition, the normal peristaltic waves are replaced by spontaneous, repetitive, and occasionally prolonged increases in pressure in response to deglutition. Symptoms: retrosternal pain, mainly dysphagia. Treatment: long myotomy from the aortic arch to the cardia. Factors promoting reflux and damage: dysfunction of the cardioesophageal junction and gastric distension. Dysfunction of the cardioesophageal junction is divided into three items: primary weakness of the lower esophageal sphincter, hypotensive lower esophageal sphincter, short length of the intra-abdominal esophagus, hiatus hernia, abnormal high number of transient lower sphincter relaxations, gastric distension, impaired gastric emptying, whether organic gastric outlet obstruction or functional due to food, which slows gastric emptying like fat, coffee, and chocolate, may contribute to reflux. Clinical picture: symptoms and signs. Signs: anemia, hematemesis in severe cases of esophageal erosion. Symptoms: we have typical and atypical symptoms. Typical symptoms: heartburn, dysphagia, odynophagia, regurgitation, and water brush. Atypical symptoms: chest pain simulating coronary artery disease, pulmonary manifestations simulating bronchial asthma, laryngeal manifestations as persistent by cough, change in the voice, or choking episodes. Complications: variable degrees of erosions, ulceration, and bleeding, strictures and shortening of the esophagus, Chasky ring, Barrett's esophagus, columnar metaplasia of the stratified squamous epithelium of the lower esophagus. Metaplasia may be gastric or intestinal. Intestinal can develop into adenocarcinoma. Investigations: pH study, esophageal manometry, and upper GI endoscopy. pH study: the best investigation if the timing of these reflux symptoms coincides with low pH recording. Symptoms are due to reflux. A small probe is passed through the nose to be positioned 5 cm above the lower esophageal sphincter. The probe is connected to a digital recorder worn on a belt for 24 hours. The collected pH changes are then analyzed by a computer system. The patient is asked to record when he gets the symptoms of the reflux. Esophageal manometry: to test the pressure of the lower esophageal sphincter. Upper GI endoscopy: it can evaluate the degree of esophagitis, diagnose presence of hiatus hernia. Biopsy can be taken if suspicion of Barrett's esophagus or malignancy is present. Endoscopic grading of reflux: grade 1, 2, 3, 4. 1. Hyperemic mucosa. 2. Intermittent superficial ulcers. 3. Extensive ulceration. 4. Stricture or Barrett's esophagus. Fat dyspepsia is more common in GERD than gallstone diseases. Symptoms are aggravated by posture, lying flat, bending, and stopping. Can be severe, especially at night and after large meals. Conservative treatment is the main line. Lifestyle modifications: weight reduction, which markedly improves symptoms, stopping of smoking, avoidance of large, fatty, spicy, and acidic meals, alcohol, chocolate, and coffee, avoidance of recumbence after meals for at least 2 hours, elevation of the head and bed 15 degrees to reduce reflux. Medications: antacids, H2 receptor blockers, prokinetic drugs, proton pump inhibitors. Surgical: 10 to 15% will be referred to have anti-reflux surgeries. Indication: failure of medical treatment, development of complications as severe esophagitis, persistent anemia, esophageal stricture. Atypical symptoms: respiratory, pharyngeal, and dental. Non-compliance of the patient. Procedure: anti-reflux surgery. Nissen fundoplication includes complete wrap of the fundus of the stomach around the lower esophagus 360 degrees to create a high pressure zone. This operation can be done by open or laparoscopic surgery. Barrett's esophagus: 10% of cases of the GERD, metaplasia of lower end of the esophagus mucosa into columnar type, Metaplasia may be gastric or intestinal type. Intestinal type is precancerous, resulting in adenocarcinoma. Regular endoscopic monitoring with multiple biopsies is essential. Endoscopic mucosa resection using photodynamic therapy or argon beam coagulation can be used before progression to cancer. The best line treatment is large dose of proton pump inhibitors. Esophageal hiatus hernia is divided into acquired and congenital. Acquired is divided into sliding hiatus hernia, paraesophageal hernia, and mixed. Sliding hiatus hernia definition: the cardiac orifice and adjoining stomach part herniates through the esophageal hiatus in the diaphragm into the posterior mediastinum. Etiology: increased intra-abdominal pressure as in pregnancy, obesity, decreased elasticity of the right crust as in obesity and old age. Pathology: cardiac orifice herniates through the esophageal hiatus, a small empty peritoneal sac on the left side of the stomach. The esophageogastric junction is displaced into the chest, leading to reflux of acid gastric juice. Effect on esophagus mucosa: esophagitis, ulceration, metaplasia, intracolumnar cells, Barrett's esophagus, which is precancerous. Effect on muscularis mucosa: circular layer, shows spasm, fibrosis, structure, longitudinal layer, spasm, pulling the stomach upwards, more herniation, vicious circle. Clinical picture: type of the patient, more after the age of 40 years and it's more common in females. Symptoms: commonly asymptomatic if the episodes of reflux increase. Clinical picture of GERD. Investigations: barium meal in Trendelenburg position. The hernia appears as small epinephric bulge, reducible in erect position, widening of the esophageal hiatus, reflux of barium from stomach to esophagus. If there is esophagitis, leads to irregularity of the esophageal lumen with granular mucosal pattern. Perform investigations of GERD. Treatment: sliding hernia alone doesn't need any treatment, only indication for surgery, severe symptoms or complications. Principles of operation: reduction of the hernia, maintaining segment of the esophagus intra-abdominally, performance of an anti-reflux mechanism, Nissen's fundoplication, repair of the right crust of the diaphragm. Presence of hiatus hernia on a barium meal study doesn't necessarily mean that symptoms of the patient are due to it. Hiatus hernia may occur without reflux, and there may be reflux without a demonstrable hiatus hernia. Paraesophageal or rolling hernia definition: true herniation of the stomach or part of it through esophageal hiatus in front of the esophagus in the posterior mediastinum. The esophageogastric junction lies below the diaphragm. No reflux esophagitis. Clinical picture: compression of esophagus leads to intermittent dysphagia. Heart: cardiac symptoms as palpitation, postprandial pain confused with angina, phrenic nerve hiccup. Complications: strangulation of the herniated stomach leads to pressure necrosis or rupture, mediastinitis, or empyema. Investigations: plain chest x-ray and barium meal. Plain chest x-ray shows gastric gas shadow in the chest, barium meal herniated stomach, and the esophageogastric junction is in its normal location. CT scan of the chest and upper abdomen should be done before planned surgical repair. The pain occurs after meals due to distension of the intrathoracic stomach. Treatment: surgical to avoid fatal complications by abdominal approach. Steps: stomach is retracted downwards, hernial sac is excised, and the defect is closed. Investigations, as we have mentioned, don't forget plain chest x-ray and barium meal. Carcinoma of the esophagus. Pathology: site recently lower third, more than the upper 2/3, macroscopic, annular serous lesion, malignant ulcer with raised everted edges, fungating cauliflower-like friable mass, microscopic adenocarcinoma in the lower third of the esophagus on top of Barrett's esophagus, or squamous cell carcinoma, which is the commonest in the middle third. Spread: direct, lymphatic, and blood. Blood late to lung, liver, ribs, or vertebrae. Lymphatic spread early. Cervical esophagus, deep cervical lymph nodes, thoracic esophagus, posterior mediastinal, tracheobronchial lymph nodes, abdominal esophagus, left gastric and celiac lymph nodes. Direct spread spreads in circumferential and longitudinal directions of the wall of the esophagus. Malignant cells extend in the submucosa many centimeters beyond the palpable edge of the gross, so large safety margin needed during resection. Penetration of the muscular wall occurs, and infiltration of the adjacent structures such as trachea, pleura, diaphragm, pericardium, stomach, and recurrent laryngeal nerves. Incidence: Age after 50 years old. Sex more in males, except in the cervical esophagus, which is more common in females. Predisposing factors. Barrett's esophagus, this is the most important factor. Chronic irritation by certain diets as spicy food, alcohol intake, and smoking. Corrosive stricture of the esophagus, achalasia. Long-standing reflux esophagitis. Characters of dysphagia, progressive, continuous, and at first for solids, for soft diet, and lastly for fluids. In advanced cases, the patient cannot swallow his own saliva. Continuous drooping of saliva leads to aspiration pneumonitis. By the time the patient complains of dysphagia, about 2/3 of the circumference of the esophagus are involved by the tumor. Clinical picture. Type of the patient, male, more than 50 years old. Symptoms, dysphagia, regurgitation, severe and progressive loss of weight, hematemesis, and symptoms due to infiltration of the adjacent structures. Dysphagia is the main symptom. Regurgitation leads to pulmonary problems. Hematemesis, not a common symptom. Symptoms due to infiltration of adjacent structures, such as change of voice if the recurrent laryngeal nerve is affected, or recurrent shocking due to tracheoesophageal fistula. Signs, general and local. General, cachexia, dehydration, chest infection, and jaundice. Local, neck for lymph nodes, enlargement or mass, chest, pleural effusion, abdomen, hepatomegaly, and ascites. Investigations, for diagnosis and for staging. For diagnosis, barium swallow and esophagoscopy. Esophagoscopy demonstrates the lesion and take multiple biopsies. Barium swallow, cauliflower-like lesions, persistent irregular filling defects. For serous lesions, irregular narrowed segment with overhanging margins, shouldering or apple core. Peristaltic waves may be absent above the lesion due to submucosal infiltration of the esophagus. Differentiate between carcinoma and achalasia. Carcinoma, mild proximal dilatation with irregular termination, rat tail. Achalasia, severe proximal dilatation with regular termination, named parrot peak. Indications for palliative treatment in the patients: patient with poor cardiorespiratory status, patient with distant metastasis with advanced local spread as tracheoesophageal fistula, recurrent laryngeal paralysis, infiltration of the pleura or pericardium, extensive lymph node deposits. Investigations for staging: bronchoscope, plain chest X-ray, abdominal ultrasound, endoluminal ultrasonography, CT scan, and PET scan. Bronchoscopy in lesions of the upper esophagus, detect infiltration of the trachea and bronchi, done before barium swallow because if there is fistula, barium passes into the trachea. Plain chest X-ray detects pulmonary deposits or malignant effusion. Abdominal ultrasound reveals liver deposits and ascites. Endoluminal ultrasonography shows invasion of the mediastinum and lymph node enlargement. CT scan demonstrates the extent of the lesion, presence of lymph deposits, and presence of infiltration of the adjacent structures. PET scan assess nodal and distant metastasis. Treatment: inoperable tumors, we have 60% of them. Treatment is palliative. Aim: relieve dysphagia and allows the patient to swallow. Methods of palliation: intubation, the best method, and radiotherapy, laser photocoagulation, and gastrostomy. Intubation: insert a rigid tube through stenosed segment, patent lumen. Methods of insertion: tubes which are pushed through the lesion by esophagoscopy, Suture tube, and tubes which are pulled from below after doing gastrostomy, Celestin tube. Radiotherapy, suitable for carcinomas of the upper esophagus. The dosage: 4,000 to 4,500 rads over a period of 4 weeks. Complications: hemorrhage, perforation, and pneumonitis. Laser photocoagulation, YAG laser. Laser energy causes tissue coagulative necrosis. Complications include chest pain and possible perforation. Gastrostomy, performed when there is no other alternative. It doesn't relieve the patient from the inability to swallow his own saliva. Operable tumors, 40% of the cases. Treatment is radical surgery. Aim: to cure the patient. Indications: patients in good general condition and localized resectable without distant metastasis. The idea: resect the lesion with an adequate safety margin on either sides, 10 centimeters. Restore the continuity of the gastrointestinal tract. Types of operations: transhiatal oesophageectomy, the preferred surgery nowadays, and for tumors of the lower third of the esophagus, and we have Ever-Lewis approach. Transhiatal esophagectomy, the preferred surgery nowadays. Thoracotomy is avoided by mobilizing the esophagus from the abdomen by diaphragmatic hiatus and by neck incision. Then esophagogastric anastomosis is performed in the neck. Advantages: it guarantees adequate safety margin. The stomach can be mobilized easily. Anastomosis is in the neck. If leakage occurs, it doesn't lead to mediastinitis or empyema. No need for thoracotomy. For tumors of the lower third of the esophagus, do left thoracoabdominal incision, then excise the esophagus and the upper portion of the stomach, and esophagogastric anastomosis is performed. Ivor-Lewis approach for tumors in the middle third, not widely used. The stomach is mobilized through midline incision, then thorax is opened through right fifth intercostal space, esophagus is excised down to the cardia, then esophagogastric anastomosis is done. Esophageal replacement surgeries: gastric pull-up, colon replacement, pectoralis major microcutaneous flap, and free jejunal replacement with microvascular anastomosis. Gastric pull-up idea: mobilization of the stomach completely into the neck with preservation of the right gastric and right gastroepiploic vessels. Advantages of the gastric replacement: the stomach has very rich blood supply, complete serosal covering, and easy mobilization. Colon replacement: segment of the right or left colon is mobilized with preservation of the feeding artery and vein and the marginal artery near the wall of the colon. The colon is anatomized below to the stomach and above to the cervical esophagus. Pectoralis major myocutaneous flap can be used to replace localized segment of the cervical esophagus. The skin segment is rolled up itself to form a tube with the epidermal surface facing inwards. Free jejunal replacement with microvascular anastomosis: segment of jejunum is separated with preservation of the feeding artery and vein. Using microvascular techniques, the feeding artery is anastomosed to the inferior thyroid artery in the neck, and the feeding vein is anastomosed to one of the veins in the neck. Dysphagia. Definition: difficulty in swallowing. Causes: in the mouth, stomatitis, glossitis, neoplasms of the tongue and the cheeks. In the pharynx, mechanical and neuromuscular. Mechanical: pharyngitis, retropharyngeal abscess, Plummer-Vinson syndrome, pharyngeal diverticulum, post-cricoid carcinoma. Neuromuscular: diabetes, myopathy, and poliomyelitis. In the esophagus, mechanical and neuromuscular. Mechanical: in the lumen, foreign bodies in the wall, congenital stenosis, traumatic as corrosive or post-operative stricture, inflammatory as in reflux esophagitis, neoplastic as carcinoma, compression from outside, malignant thyroid, malignant lymph nodes, aortic aneurysm, mediastinal tumors. Neuromuscular causes: achalasia of the cardia, paralysis of the glossopharyngeal or the vagus nerve, tetanus, myasthenia gravis, hysteria. Investigations: chest x-ray, barium swallow, pharyngoscopy or esophagoscopy, CT scan of the chest. Odynophagia means painful swallowing. Therapeutic uses of esophagogastrodiadonoscopy: band ligation or sclerotherapy of esophageal varices, controlling bleeding from peptic ulcers by submucous adrenaline injection, laser or hemoclips. Bleeding superficial gastric erosions can be controlled by argon beam coagulator. Percutaneous endoscopic gastrostomy or PEG. Dilatation of benign esophageal structures and or achalasia, as well as dilatation of the pyloric obstruction. Stenting of malignant structures of the esophagus and tracheoesophageal fistula. Recently, areas of esophageal dysplasia or Barrett's esophagus can be ablated by endoscopic mucosal resection (EMR) or photodynamic therapy. Removal of swallowed foreign bodies, ERCP with removal of CBD stones, common bile duct stones, dilatation or stenting of biliary structures. And this concludes our part for esophagus.